So the combination of bortezomib, lenalidomide, and dexamethasone is considered to be one of the current standards initial treatment of myeloma. Now, this is based on data from several trials, but most importantly, the SWOG-S0777 trial that compared BRD to RD and showed that there was an improvement in response rate, progression-free survival, and most importantly, overall survival. So this regimen is used in the non-transplant setting as well as in the transplant setting. There have been other phase 3 trials that have looked at BRD as injection therapy before going to an autologous stem cell transplant, particularly in the French trial IFM 2009, which compared early to delayed stem cell transplant. So we know what to expect in terms of efficacy. The main toxicity that we see with BRD is the neuropathy that can limit the duration for which this drug is given or the combination is given. So that is indeed one of the biggest drawbacks of the regimen, which is ameliorated to some extent by giving the bortezomib weekly and also giving it subcutaneously. However, with all these trials, the median progression-free survival is somewhere between 3 to 4 years. So there's clearly a lot of room for improvement there. So we continue to work on trying to get better treatments. The entrance trial was designed to see if carfilzomib, lenalidomide, dexamethasone would be a better triplet to treat myeloma with compared to the bortezomib, lenalidomide, and dexamethasone. We designed the trial because some of the phase 2 studies had shown that carfilzomib Lendex produces deep and more frequent responses in newly diagnosed myeloma in albeit smaller trials. Based on those results, we designed the Even 11, which randomized newly diagnosed myeloma patients in whom an early transplant was not intended and who did not have high-risk features like translocation 1416, 1420, deletion 17p, and plasma cell leukemia or elevated LDH. To receiving either carfilzomib, lenalidomide, dexamethasone or bortezomib, lenalidomide, dexamethasone in a 1:1 fashion. Patients who were assigned to the VRD arm received bortezomib, lenalidomide, dexamethasone in 3-week cycles for a total of 12 cycles. Patients who were assigned to the KRD arm received carfilzomib, lenalidomide, dexamethasone as 4-week cycles for a total of 9 cycles. At the end of the injection therapy, patients were randomized a second time to receiving lenalidomide maintenance either for 2 years or indefinitely until disease progression. So the main finding was obviously the primary endpoint for the trial, which was progression-free survival. We found that the progression-free survival was similar both for the VRD and the KRD at about 34 months from the initial randomization. We noted that the overall survival with the current follow-up is also identical between the two arms at about 85% at 3 years. The overall response rate was about 85% in both arms, with more frequent deep responses like EVGPR in the carfilzomib arm. We also noted that there were more grade 3 and 4 grade 3 or higher non-hematologic adverse events in the KRD arm compared to the VRD, particularly cardiac, pulmonary, and renal toxicity, while there was increased frequency of neuropathy in the bortezomib arm, with almost 8% of the patients having a grade 3 or higher peripheral neuropathy. We also noted that the quality of life measurements appear to be quite comparable between the two groups. So we found the higher rates of grade 3 and higher cardiac, pulmonary, and renal adverse events in patients receiving the carfilzomib Lendex combination. When we looked at the side effect profile, these were the ones which really stood out as different between the two, the neuropathy for the VRD and the cardiac, pulmonary, and renal for the KRD. The when we looked at the age, it was clear that the older patients tended to have more frequent of this cardiac, pulmonary, and renal toxicity as well. We did notice that almost um, 43% of the patients in the BRD arm, 61% of the patients in the KRD arm completed the injection cycles as planned, with the rest of the patients dropping off or discontinuing injection therapy earlier due to adverse events or patient preference and or institution of alternative therapy. We found that nearly about 28% of patients in both arms went on to get a stem cell transplant. But even factoring in all these different differences, the PFS still appeared to be comparable. So I think the major differences are going to be developing multi-drug combinations that can get us to a very deep response in these patients, which then in turn might allow us to discontinue therapy after a period of time, but also improve the probability that we might completely eradicate the clone and cure some people. The second, in addition to making the multi-drug combination regimens, we may have to incorporate the immunotherapy, say the part of the initial therapy, or as a approach to eradicate residual disease after the initial treatment in patients with myeloma. Um, in terms of the heterogeneity that we see in the disease, I think we may have to think about approaching these diseases differently based on the underlying findings or underlying differences, so that some treatments might be more effective in certain cytogenetic subtypes compared to the others. So those are things that we need to work on.